Hi, everyone, and welcome to another edition of Collateral Nation with Dr. Chris Seenan. He is a world-renowned researcher on walking as therapy for people with a disease that's more prevalent and deadlier than most cancers combined, known as peripheral artery disease, which is poor circulation in mainly the legs. Surprisingly, the best medicine for peripheral artery disease is walking. And it's so counterintuitive because when you walk, you have pain. And when you were a youth and you were an athlete and you ended up with a cramp in your leg, your coach would say, "Whoa, stop. No, don't push through it. You're going to hurt yourself." But it's the opposite when you have PAD. When you feel that cramp, what we call claudication, you want to walk through it. You want to push through it. It is during the time you are pushing through that pain that you are building your collateral network of vessels, your natural bypasses. Your body is saying, "Hey, give me more blood flow, give me more blood flow." And your body starts building these detours. And through that process, pushing through the pain also teaches your body to adapt to less oxygen, less blood flow, and says, "Hey, you got to do more with less." That's about all I have for you. So let's turn it over to Dr. Chris Seenan, a world renowned researcher from Glasgow, Scotland, to talk about more on pain and walking and how to manage that pain so that you can walk further and faster. Welcome, Dr. Seenan.
Thank you so much for having me. And hello, everybody. Very nice to be here and to talking to you all. So today I wondered if it would be okay to share some information a bit about what we've been doing in terms of our research projects. So often kind of I'm here talking to you all, answering kind of questions, but over the past few weeks, a couple of times people have asked about, well, what research has actually been doing on this, is going on in terms of this condition, and what people have been looking at. And again, over the past few weeks, I've also been sharing some information about studies that we are doing at the moment. But to give you a bit more background and information, and to focus a little bit on pain, as Kim's saying, I thought it'd be useful to kind of share some of the stuff that we've been doing over the past few years. So I'll share my slides just now, or share my screen, and hopefully you'll be able to to view my presentation. But the idea being today is I would like to talk through some of these, talk through the work that we've been doing. If there are questions, hopefully that might prompt some questions as we go. If there are, then I'm happy to stop and answer those, or we can kind of talk a wee bit more towards the end. So just to introduce myself first of all, so my name is Chris Seenan. I'm a physiotherapist and a senior lecturer at Glasgow Caledonian University, and I have a PhD in pain and vascular disease. So pain was where I kind of came from, and it was just through applying it to the problem of peripheral arterial disease that I got into looking at kind of more about intermittent claudication and PAD in general. So as I mentioned, I'm going to just share some information about what we've been doing. So this here is a bit of a brief summary of what I'll try or I'll be covering today. And I'm going to explore these points one by one, starting with an exploration of the problem of PAD and IC. So I'll talk about it as PAD and IC just in short, so I don't have to keep on saying peripheral arterial disease and intermittent claudication, but that's what I mean. But I'm also I'm going to focus on physical activity and highlight some of our research. So let's get into it then. But what is the problem? And I'm very aware I am talking to a room full of experts here, and more people online. So I don't want, and I don't mean to be patronising by this, but I thought it would be really important just to kind of establish some of the basic definitions to make sure we're all on the same page. So IC, first of all, or intermittent claudication, which is the main symptom of PAD. It's normally described as aching or cramping in the lower limbs, but it can occur in the thigh, the buttock, calf, or foot. And what I've learned over my time of exploring this condition is that it's very different for every individual. So some of you might experience it only in your feet, some people in your feet and your calves, or other people at different places at different times. What's important to recognize is that the experience of IC is independently associated with increased functional disabilities. What I mean by that is that feeling the experience of this pain means that, and this is again fairly common sense, is that you are less able to do things that you want to do. So again, we're less able to go to the shops, work, participate in daily life. The other thing it's associated with, though, is psychological distress and increased risk of morbidity. So on top of, we mentioned already that PAD is a condition that's associated with kind of risk of other kind of significant problems and death, but having the pain itself is on top of that related to kind of psychological distress and death as well. So regardless of the severity of your PAD and other factors such as your age, gender, smoking status, if you have claudication, you're more likely to have reduced function, experience psychological distress, and more likely to develop other health problems. So claudication is not a good thing, right? The other thing to establish is PAD. So PAD is a clinical manifestation of cardiovascular disease. And so it describes this process of atherosclerosis in the arteries out with the brain and the heart. So PAD, even though we talk about it in the lower limbs, it is anything that occurs out with the central kind of cardiovascular system. And atherosclerosis, as by definition, is systemic, which means it's happening all over the body at the same time. And as you can see by these figures in the second statement, bullet point here, affects a significant proportion of the population. One thing to recognize, and again, I know from the conversations that you all know this, probably know this already, but PAD is underdiagnosed. So it's one of the top 5 most underdiagnosed diseases. So it generally comes from this lack of awareness. So people who are over 50 years of age should generally pay attention to the aches and pains in their legs. It's normally not natural aging. It is something to be concerned about often. So the statistics here is that it's globally underdiagnosed. In 2021, it was established that PAD impacts an estimated 20 million Americans, yet only 8.5 million Americans are diagnosed. So if you know, so there's a significant proportion of people out there who have the condition who are undiagnosed or unaware that they have this condition. And interestingly, from that study, the authors were saying women in particular suffer an immense burden from peripheral arterial disease, and yet the data demonstrate most women still remain unaware of their risk. And it's that old adage of women generally just get on with things, and it's men that do all the complaining and worrying. But sorry, that's a very oversimplification, I'm sure. The second part of that is PAD is undertreated. So the rate of deaths and healthcare costs associated with PAD are least comparable to those of heart disease and stroke. However, most adults in the US who have PAD do not receive secondary preventive treatment that could reduce their risk of heart attack, stroke, or death. So again, and I thought it was 2011 that this study was done. But most studies that have been looked at this kind of thing link the cardiovascular endpoints, so that's heart attack, stroke, and those people who have PAD due to poor risk management, so kind of not being aware or not getting the appropriate medical interventions or treatment to kind of reduce the risk of these other things going on. And in the UK, only approximately 48% of vascular surgeons have access to a supervised exercise program, which is one of the key, the number one recommended management strategy in this condition. This was a study here that kind of illustrates this very starkly, I feel. So the study found that people with PAD receive less cardiovascular medical therapy. So things like, as you can see along the bottom here, in terms of statins, beta blockers, ACE inhibitors. So these are all the medications that you're recommended, that you would be prescribed to help manage the risk factors of this condition. And as you can see, these bars, the red bars, illustrate those people with PAD, and the green bars illustrate those who have coronary artery disease, so kind of heart disease. And I know, and within all these, you can see that it's medication use percentage up the left-hand side. And people with coronary artery disease are often get a lot more medications prescribed than people with PAD, even though they're meant to get the same amount. You know, it's the same cardiovascular risk. So hopefully all of that has established that PAD is a common progressive condition that leads to reduced function and has significant impact on morbidity and mortality, but it's underdiagnosed and undertreated. So let's think about the management of this condition. What do we do? What should be done for people with this condition? And the causes and risk factors for developing PAD are the same as those for coronary artery disease. And this includes smoking, diabetes, hypertension, so increased blood pressure, increased cholesterol, and older age. And so these are all the things that we know that we need to be addressing, or addressing what we can address. Exercise as well as an essential component of this lifestyle modification. And so this is what on the main focus of what I'd like to talk about. Because as well as having functional impacts in terms of walking distance, it also contributes to the management of the other factors. So exercise can help with weight management, with management of high blood pressure, with management of high cholesterol. So that's the beauty of exercise, is it's helping in many different ways. This diagram here on the slide is something from an old journal article, actually from 2007, but I think it illustrates this fact really, like how exercise helps really, really well. And what you can see is if you just follow the top line, first of all, is if you have people with PAD often have, if they experience claudication symptoms, so pain in their legs, if they get exercise training, if you walk, that improves the muscle strength. So I'm going to move this a second. See, yeah, improve the muscle strength and endurance, improves pain threshold, it improves the walking biomechanics, so they walk more efficiently, and it improves your muscle metabolism. So basically it makes your muscles work more efficiently, as Kim was indicating earlier. And all those things do is it increases your time to experience your pain. So it means that you can walk longer without experiencing pain, and it improves your physical activity. So it improves quality of life and decreases depression. And all of that can therefore affect, it can help reduce obesity, reduce blood pressure, reduce glucose intolerance, and reduce this dyslipidemia, which is increased cholesterol. So exercise in general has all these benefits. Conversely, if you go down the bottom way, this is this kind of decreasing and vicious cycle of not exercising. So when you experience the symptoms, it limits your physical activity, it decreases your quality of life. Generally, people with PAD experience more depressive symptoms because of not being able to do what they want to do, and that leads to this deconditioning. So more likely to kind of put on weight or increase your blood pressure, your glucose intolerance goes up, but you're likely to have an increased cholesterol and all of those things. And it also kind of, it means your muscles get weaker and they have less endurance. It makes your walking more inefficient, and you have this altered muscle metabolism, which just makes things worse. So you go round this vicious cycle again and again. So that's why it's so important to try and break that cycle, to do this exercise and to reap these benefits, reap these rewards. Yeah, so as you can imagine, and probably as a mixture of both cause and consequence, if you have significant levels of atherosclerosis causing reduced blood flow into your limbs, you're generally going to be less physically active than other people your age. So we know that people with PAD have lower levels of physical activity and higher levels of what we call sedentary behavior. But we also know that physical activity level is a predictor of mortality. So if you're less physical active, you're more likely to die earlier. than those who are more physically active. So, so if it's so essential to intervene with people with PAD, and we know that physical activity is important, what are we doing about this? Well, the current answer is not very much. So supervised exercise is recommended as kind of primary treatment for people with PAD. And participation in these interventions demonstrates benefits in walking distance and quality of life. Also with physiological anatomical changes, collateral growth, and reduced inflammatory state, lots of things. As you say, there's many benefits from engaging with exercise. Unfortunately, these exercise programs are not commonly available, and especially in the UK. And I think in the US it's similar too, but only, as you mentioned, only 48% of vascular surgeons have access to these type of programs. The other problem is there's limited evidence that these interventions themselves, the supervised exercise, actually lead to improvements in physical activity. It's actually more often it's people who do things themselves and adopt lifestyle changes that have more prolonged kind of impact or increased physical activity, which I think is what I've seen in this group as well from what people report. So where does that leave us? Well, basically, we've established that PAD is common, it's underdiagnosed and undertreated, and physical activity is important. And it's important for cardiovascular health and also improving quality of life. So this is where it gets to where we come in. Okay, so researchers that I've been working with have been exploring physical activity behavior in people with PAD from the early 2010s. Basically, we started in 2018. We conducted this review. So this is a systematic review where we search all of the literature, all of the published studies, to look to kind of summarize the evidence in a certain area. And what we wanted to do here was to work out, well, what are the barriers? What are the enablers? What's stopping people and what's helping people to do physical activity when they have PAD and IC? And what I've highlighted here are the most commonly reported barriers and enablers. So as you can see, the barriers were things like pain, lack of knowledge and understanding, lack of motivation or weather or the environment. And the enablers were things like support systems, like groups of people that would help support, or friends and family that would support them to be more physically active. Cognitive strategies in terms of ways they think about being active, and also positive beliefs that the activity was going to help them. And the other thing was the availability of exercise programs. So we used this evidence to help develop interventions, and specifically focusing on these things I've highlighted in red, because there was not much we could do about the weather, unfortunately. So we've also been completing some initial development and testing of interventions. So as you can see, what we focused on first of all is we focused on education and we focused on pain management. So in a proof of concept study, that's when we just a very initial kind of study, we demonstrated that pain management in the form of TENS. Over here in 2016, we showed that using a TENS machine while walking on a treadmill helped improve pain-free and maximal walking distance. So it improved the time before you experience pain and also how far you could walk into pain when walking on a treadmill. And our colleague down in Northumbria, Professor Gary Chu, was looking at the effect of education. And so they developed a patient-centered group education. So got a group of people with PAD and IC together, delivered a kind of workshop about what PAD and IC is and working on physical activity, and found that increased physical activity after participating in this workshop. So based on these two initial studies, we developed what we've called the PrEPAID study, the PrEPAID trial, which was aimed to explore if these interventions were feasible to test in a full trial. So and we've published each of these things as we've gone. So let's talk a little bit more about this PrEPAID trial, because this is what our most recent work that we've done, and we're working on publishing it at the moment. So the trial was funded by the Scottish Government, which through the Chief Scientist Office, and it was a collaboration between us at GCU, at the University of Glasgow, Northumbria University in Newcastle, and the NHS Greater Glasgow and Clyde, which is our local health board. And what we wanted to know was basically, and this is all quite technical language, but we wanted to know is, could we do this study? If we put pain management and education together and as an intervention for people with PAD and IC and try to test it, see if it works, would people with PAD and IC be willing to take part in that trial? Because that's one thing that's really important. There's no point doing a huge, big clinical trial if people are like, well, I don't want that intervention. That's not going to be something that that would be useful to me. And the other thing is, if it's too inconvenient, if it's saying, well, I would love that intervention, but there's no way I'm traveling 2 hours to take part in that trial. So this was the context of this study that we did. Again, it's a bit probably detail heavy here, but this just shows you the process of the clinical trial. So the diagram on the left here is the kind of the flow diagram of how people went through the trial. So we first of all identified people from the vascular clinics, so where they were going to be diagnosed, and we looked at whether they were eligible to take part in the study by looking at their kind of medical history. Then, if they were eligible, we'd invite them to take part, and if they agreed, they would come, and they would come for a visit on the first time, where we would go through a battery of tests, do a treadmill test, do some questionnaires, and look at ABPI and other things like that, and then come back on a second. We would give them an activity monitor to look at kind of how many steps they were doing that week, and they would come back the second week for a second test, and this was all to see if they were eligible to take part. If they were then randomized to one of the 4 groups. So we had 4 different groups in this study. We had one with active TENS, one with placebo TENS, one with active TENS and the education. So they got a TENS machine and they got the education intervention, and another one where they got a placebo TENS and the education. And I'll go through a bit more what I mean by these things, what these interventions were in a minute. They did that for 6 weeks and then came back, and we tested them again to see what had changed, basically. And at the very end of the study, we did a focus group, or what turned out to be interviews in the end because of COVID-19. But we were to look at how the patients felt about participating in our trial. And we were looking to recruit about 80 people with PAD and ICs, quite a small study. So the 2 interventions we looked at, one was TENS, and now if you haven't come across a TENS machine before, it stands for transcutaneous electrical nerve stimulation. It looks a bit like this, or this was the exact device we used in the study, but you kind of have this small device that fits roughly on your pocket or clips to your belt, and these electrodes here stick onto your skin and are attached by the leads to the TENS machine, and we basically would train someone to use the device, giving them to take home, and they were to wear it every day as often as they could, and when they were awake, and switch it on when they're standing or walking or about to engage in an activity where they would anticipate feeling pain. So the whole point of this is pain relief. So the TENS machine, the electrical current is transmitted across the skin. When you turn the TENS on, you feel a kind of a buzzing or tingling sensation, and that helps distract you from the pain. In terms of the education intervention, it was a one-off 3-hour structured group education session, plus kind of twice weekly phone calls for the 6 weeks following the intervention. So the aim of this intervention was to it followed what we call the CEDRIC curriculum. So this curriculum has been developed, as I mentioned, by our colleagues in Northumbria University, and it was based on a diabetes education structured education session, and it was all focused on the knowledge and perceptions about the disease, risk factor modification, and self-management of walking behaviour. And so we basically, during that session, the participants would set goals for their walking. We would give them a pedometer. They would go home and try to achieve their walking goals, and we would phone them every couple of weeks to see how they're getting on. So what did we find? Well, this just kind of, again, might not mean much, but this was the kind of data from our feasibility. So we assessed over 1,000 people for eligibility in the study. Of those, we excluded about just over 700. So there are a lot of people who weren't appropriate for the trial, and the reason for that being commonly was that they didn't have PAD. So these are the people that were attending a claudication clinic to be diagnosed. So we didn't know if they had PAD yet or not. A lot of them found out that it was some other condition that was causing the pain in their legs, and so that was why they're not eligible. Or the other thing is the PAD was too advanced at that stage, because we didn't include anyone who had what we call chronic limb-threatening ischemia, so anyone with pain at rest or things like that. We approached just to kind of 267 people. We screened almost 100 people, and we randomized 56 in the end. So 56 people participated in the trial, and were randomized across the different groups. In terms of attendance at the group education session was 96%. So a lot of people came along to the group. Only 63% complete the follow-up phone calls, however. And in terms of TENS, what we asked is we wanted to find out if people used the TENS machine, if they were given it, and it was about 70% about the participant completed logs. But the TENS machine also recorded when the device was switched on and off. So we had that kind of record of actually whether or not people did use the TENS or not, and that figure was a bit lower according to, but there were some issues with how that was recorded. And we only had 3 what we call adverse events. So these were things where the intervention didn't really work. So 3 participants reported they didn't like using the TENS and stopped using it because it was quite itchy underneath the electrodes from where it was on their legs. So what about in this trial, I remember, if you remember, the questions we're answering is not whether TENS in education work, but whether or not this was a feasible and acceptable study to conduct. Sorry, Kim, I just seen your message there. Yeah, I think that's what this study did show, was that, well, in the group that we had, so the 56 people, that they all had a TENS machine, that only 3 of them had these adverse events, and they were quite minor adverse events in terms of the itching. There wasn't any kind of safety concerns with the device, and again, the TENS is a standard device you can buy over the counter in a pharmacy or online. So it is quite a safe, and the other thing is a non-pharmacological method of pain relief. And that was the part that was really useful about this, is because often people with PAD take a lot of medications. You've got to take a lot of medication to manage all the other aspects of the condition. What you don't need is another medication for pain that might well interact with some of those other drugs, other medications. And the other thing is, the problem with medication for pain relief is that, generally you take a pill and it works constantly, like all day, or it works for a while, then drops off, and you have to take another pill, and then the pain relief comes back. With claudication, obviously, it's what we call a transient pain. So it only comes on when you're walking. As soon as you stop, it generally goes away, and then it comes on when you walk. So you just need pain relief when you need it. You don't need it all day. So that's that's what TENS can deliver, because it only works when the TENS machine's turned on. When you turn the TENS machine off, you don't get any pain relief. And so that was the idea why TENS might help. But I think this is what you're about to see, I suppose, is that it's not for everyone, and that and that's why we're still investigating it, because we don't know it actually works for PAD. It's never been tried for PAD before, particularly. But yes, there are. That's the idea. Is we're trying to see if it might work. So in terms of acceptability was our other bit that we were interested in. Remember, I mentioned that we did interview our focus groups with the people that participated in the trials, who took part, because we wanted to know, how did they feel about taking part in this study, and what did they feel about the interventions. So the participants who received both TENS and education were invited to these interviews, and I'll summarize some general themes or quotes from the participants. So Liz, not her real name, but Liz, this is what Liz felt about it. So she was able to walk much further with TENS, and felt it helped her to avoid the surgical intervention. So that, saying I can walk much longer periods without the pain coming on, which is what she'd hoped to gain from it. And so it's this part. She felt positive because they avoided having surgery on the leg. The surgery was not the right option after participating in this study, and saying that it was obviously had an improvement. For Andrew, interestingly, he was talking a bit more about the education session. He said that improved knowledge about the condition has led to a change in outlook. So they feel better knowing more about it. But, he was reflecting, and so that's always the case with everything. Most negative feelings come from a lack of knowledge, which I think was quite insightful and interesting about, and probably something which is maybe we see in this group as well, I suppose, as the more people find out and get support from the less fearful the condition is. Shona, as you can see here, felt that the TENS helped her work further too, but and that everyone with PAD and IC should get one to help with the pain. So Shona was a person that it worked for, but it wasn't necessarily for everyone. So for her, the pain was sufferable. The pain was there, but it's a little bit more manageable, and that is a big difference for her.
And
And
Marcia has a really good question
sorry, Marsha.
in here. She said she has a TENS unit, but it's old and large. You wouldn't need to get a prescription for a new one, just the ones he's talking about are over the counter. So maybe he can go into what you look for in one. But she asks, is it simply a distraction to the pain, or does it actually help to reduce the pain?
Well, that's it's a really interesting thing. I mean, this is something about the nature of pain. So TENS itself, I'm just trying to think how best to word this. So if you think about what's going on in the tissues, okay, so what's happening in the leg that causes the pain. So our understanding of claudication pain is that with the reduced blood flow to the area, when you walk, your body requires more oxygen. Because in PAD, there is not enough oxygen getting to that area, what happens is the body, it changes, the metabolism changes from aerobic to anaerobic, and it produces more lactic acid and other metabolites which change the environment in the muscle, basically. So what happens is the tissues become more acidic, or it's more acidic within the tissues, and what that does is sensitize the nerve endings. So then there's nerve endings in your muscles which specifically are perceptive to that, and they say, okay, so there's then what happens is this thing called peripheral sensitization. So it's more easier for these nerve endings to pass messages up to the brain to say there's something going on here, I don't like it, it's becoming more acidic, and that's where you experience pain. There's also a suggestion that PAD pain comes from neuropathic issues as well. So the longer you have this, if you have a kind of prolonged poor circulation to into your limbs, into your legs, that over time the nerve fibers might be affected as well, because they require blood supply as well, and there can be a neuropathic component to the pain as well. But and so generally this is what's happening in the tissue. So there's a lack of blood supply, there's a sensitization. With TENS doesn't do anything to change that. It's not changing, it's not increasing the blood flow to the area, it's not going to change how those, the environment that those nerves are sitting in. But what it does do, as you say, is the distraction. And so the way TENS work, it's through a theory called the pain gate theory, which was established in 1965 and is the basis of almost all of our pain medication. So opioids work partly through the pain gate mechanism. Now, it's the kind of the summary of pain gate is the kind of adage that you can only feel one pain at one time. So so if you bang your elbow and stub your toe, generally you only really feel one of those pains. Your brain can only perceive one of those pains at that time. And also the way that when you if you bang your elbow, the first thing you do is generally go to hold it and rub it. And by rubbing and touching your elbow, it makes it feel better. The reason for that is all to do with this pain gate. So the way that pain messages are processed in the body is that from your, say, I'm going to use this banged elbow as my analogy, but you have a sore elbow, and so the nerve fibers in your elbow are passing signals up into your spinal cord. From your spinal cord, it goes up to your brain, the centers in your brain which process the pain, and the brain decodes those messages and says, oh, there's pain there. Okay, there's pain in my elbow. But the way the messages get sent up, the pain sensing fibers are quite thin nerve fibers, and they're also what we call unmyelinated. So they're not covered in a kind of coating. They're kind of raw fibers. And so the messages get passed along those fibers quite slowly towards the spinal cord. Set different to the pain fibers, your nerve fibers that process kind of touch sensations are thick, and they're myelinated. They're covered in this kind of myelin sheath, and so they pass signals very quickly. So that's why you can kind of feel the touch of a feather, and you're generally quite sensitive to touch sensations rather than pain. And the way that the pain gate mechanism, so the pain gate is something that kind of occurs in your spinal cord, is that the body can almost only pass up one of these messages. So it has to make the choice of, do I pass this pain message that's coming from my elbow, or do I pass this touch sensation when you start to rub your elbow with your hand? And so generally what it does, because the touch sensations are coming more quickly and more strongly, it preferentially passes the touch sensation. So the pain is still there, it's just not passed up to your brain. And so what happens is you think, oh, my elbow is less sore because you're feeling the touch rather than the pain. You still feel some of the pain, but it's less. So that's exactly the same way that TENS work. So what TENS does is as it passes the electrical current over the skin, it sensitizes, it triggers those touch fibers. And so you feel the tingling sensation rather than feeling the pain. And that's what happens in claudication. So by having the TENS machine, or this is the theory, is that by having the TENS machine and passing the electrical current over this area of skin where you'd normally feel your claudication pain, that you would feel the tingling instead. So it is a masking. It's not taking the pain away. So it's not going to mean that you never have claudication, but it hopefully makes it a bit more manageable, and therefore enables you to walk further. So it's just a gateway. It kind of overrides the claudication, as you say. Exactly, it's a means to an end. If you can not feel the pain so much, maybe you'll walk a bit further that time. You walk a bit more regularly, and then hopefully it's the walking that'll change the environment. It's the walking that'll improve the circulation to your leg. The TENS is just a kind of a helper to kind of to get you there. Does that make sense? Yes, so Alan, yes, you only will work while walking. Using a TENS while sitting still is not, I think other researchers are looking at that, and there is some small evidence that indicates that if you use TENS, and even actually a really intense TENS called neuromuscular electrical stimulation, where you actually make the muscles contract as you're sitting still, that can kind of help. They suggest that might help with claudication pain, but it's through a different mechanism. It's through the release of nitric oxide and the kind of the vasodilation of your arteries.
But with PAD, if you're experiencing pain at rest, that is a red flag, correct?
Yes, yeah.
You should go get checked at that point.
You definitely get checked at that point. That means your PAD has progressed to such that at rest, your body isn't able to get enough oxygen or blood down to your muscles, to your limbs, to kind of mean that they're able to function appropriately, and that's where you need to get proper medical advice.
Any tips on keeping those pads attached, especially as you're walking? You might sweat a little bit. The sticking isn't as sticky when it gets moist from sweat.
Yes, true, right, absolutely. Sorry, thanks, Josh. I will end that in a moment. I forgot I was sharing. Yes, so a couple of things I would suggest. Some people have found that even just like using new electrodes, so often electrodes can't get the disposable electrodes, that so the minute they become less sticky, you just switch them up and use a new one. Some people use kind of elastic bandages, or we call them tubey grip. I don't know if they would be the same thing. It's those kind of, you can just put them over the top of the electrodes and they kind of help keep them on. There's brand new or kind of quite new fancy wireless TENS machines where it's all, because one of the things the participants didn't like as part of our study were the wires and the leads and the bulkiness of even having that. Even though it's quite small, it's still a bulky kind of thing in your pocket, and the wires having to pass down, especially if you're wearing shorts or a dress or something like that, and you have these wires trailing all over the place. It's quite unsightly. So, but there are wireless TENS machines where it's all built into the electrodes, and you can just place it on where you need it and control it from your phone, via Bluetooth apps or otherwise.
Where would you place the pads?
So you place them either side of your pain, is because if you remember what I was just talking there about, the idea of it is the electricity has to pass over the area where you feel pain, so that the nerve fibers in that area pick up the tingling sensation and pass on the tingling rather than the pain. So if you've got pain in your calf, well, the way we did it in our study, where we try to put one electrode above the area of pain in the calf and one electrode below, so that as the electricity kind of passes over, it would sensitize that area. If you have pain in multiple places, the best way to do it is put it in the kind of what we call the most proximal site. So the site closest to the spinal cord. So if you have it in your thigh and in your calf, put it over your pain in your thigh. And then that, because that it all gets talked, it depends on how far up your spinal cord the nerves go into. The ones higher up get kind of processed over the ones lower down. So you do it over your kind of your proximal pain.
And Marcia has a question. Marcia?
Yes. So I looked on online for a new TENS unit, and it said not for use for people with a pacemaker.
Yeah.
So I have a loop recorder inserted in my chest. Would it interfere with that?
I would not like to give you specific advice based on that, because I don't know your history and how it's worked. But what I would recommend is ask your physician, and ask for advice. What we have, what I do know in the past is only really a worry of a pacemaker if the electrical current is anywhere near the pacemaker. Generally, if you're putting this on your calf and you've got a pacemaker, it's okay. But I would just advise anyone wanting to start using a TENS machine, please go and seek medical advice just to double check, in case there's something about your medical history that means that it's not a good idea.
Thank you.
Yeah, it's always good to have that disclaimer in there that this is just for educational and informational purposes only. Always check with your healthcare team before acting on any information or advice offered here. You do need to ask your doctor if these TENS devices are right for you. Yes, you can get them over the counter. There are a lot of things you can get over the counter, but it doesn't mean it's right for your presentation of disease and right for you with other comorbidities you might have. So definitely a good idea to go ahead and get that checked before getting one of these devices. But it's such great information to know so that you can have a more productive and satisfying conversation with your doctor. I'm curious, Dr. Seenan, how did the use of the TENS device compare with the placebo? Was even the idea with those folks that had the placebo device, with those people, was it even just the idea that they had this device on there effective to help as a distraction?
Yes.
Really?
Yeah, and that was what's really interesting and about this about the study. And one thing that we have is, obviously, the numbers we've got are quite small, so it's hard to kind of really make those generalizations about, oh yeah, this will be the case for everyone. But what I think, and this is my own theory, but for people with PAD, there's so little that we can offer in terms of a treatment and something that I help. And that's one of the most frustrating parts about the condition, about the disease. So by receiving a TENS machine and people and the education that's associated with that about, well, here's something you might be able to use, and here's something that can help, and even just the kind of the trigger of like, oh, I do need to walk, and this might help me walk. I think what we found is people really that helped a lot. So there was some of these quotes that we're having from these people that said, "Oh, the 10s worked brilliant for me." We know that they were actually in placebo, but
Wow.
and so there was no current actually going to the skin, but just having a device gave them almost permission or something about it that kind of allowed them to engage with the walk.
I think that's such a powerful point to make, that your mind is incredibly powerful.
Yeah. Yeah, and it is, and that's such a big part of this condition, you know, and that's one of the things that, again, in one of our other previous studies that I have not presented today, but we looked at what was the best kind of predictor about how far someone could walk. You know, so what was it? What if you could change anything, what would help someone walk further? And the biggest thing was pain self-efficacy of the things that we measured. So what I mean by that is confidence in being able to walk further. So regardless, you could have had someone who had an ABPI, you know, a really blocked circulation system and an ABPI of 0.4 or something like that, and you had someone else with a 0.9 who's got pad, but you know, not as much blockages as the other person. But if that person with 0.4 believed that they could walk through the pain, they did, whereas that versus the other person who didn't believe as much. So it's the power of the mind is so important in this condition, because it is all about kind of how confident you feel. What do you understand about the pain? Do you know that it's not causing you harm? Do you kind of understand that you need to walk and you're motivated to walk? That's the key thing.
And what about for people who have their PAD? They might have a little bit of atherosclerosis, but their main issue is really a clotting disorder. Is there any sort of contraindication for people who have this unstable plaque in the form of clot?
I am not sure about that, and I wouldn't like to. I'll need to go and have a wee look. I think that there may be issues in terms of clotting disorders, and yeah, I wouldn't like to say one way or another based on that. But again, I guess it's check with your medical provider, your doctor, your physician, and just make sure it's safe for you in your circumstance.
I think that's always that's a good takeaway. Just make sure you do double check to make sure it's right for you. I know with my dad, he was prescribed a vibration pad, thinking that it would be right for him, but then he went to his other doctor's cardiologist and said, "Hey, wait a minute. Yes, the vascular surgeon means well, but you have, I want to make sure that your plaque is stable." And there's an investigational test they can do here called LPPLA2. And there's MM9 something or other. Anyway, some blood, I'm not a blood expert, but there were two tests that are investigational here in the US that he was able to pay for independently to discover that his plaque was stable and that he would be fine. But plaque stability is important, so it's really important to double check with your doctor before using any of these devices. And as Marcia said, if you do have a pacemaker, it also can be contraindicated, so double check with that cardiologist before picking one up. But Dr. Seenan, I know we're rounding third here. Are there any final thoughts that you have on pain management, or any final questions that I can take a look to see that are potentially coming in about these TENS devices? I think it's a really great tool if it's right for you, and great research. Is there anything that you have ongoing now on these TENS devices or other pain management tools or techniques?
Yes, yeah, there are. That was the other thing. If you don't mind, I'll share my screen again and just summarize just some of the actual the new studies that we're doing at the moment. So this is the first of them. So we are we're just kind of finishing. So we've got just the first publication. So we actually looked at, because of that indication of it's about people's psychology and motivation and how they think about it. We looked at behavior change interventions to improve physical activity. So we wanted to know, what is the evidence that behavior change strategies help increase physical activity? And what we found is that so behavior change interventions, meaning things like education or a smartphone app that helps with the motivation, or other things like that. So there was quite a few studies. As you can see, we we got 6,000 hits of different studies that have done work on this, 41 studies that are included, and over 4,000 people with PAD and IC in this study where we were summarising the evidence. So strong evidence that behaviour change interventions increase physical activity in the short term compared to non-supervised exercise, and moderate evidence that increases it in the long term. So that was the first one that we've done. This one is one that's going on at the moment. So this is called the Maverick trial, and this is about motivating physical activity through behavioural intervention and electrical stimulation. So we use TENS alongside a motivational interviewing intervention. So basically, participants kind of were talked to a physiotherapist, and it's about combining this mosaic intervention with TENS. And so we're waiting on the results of that. That's ongoing at the moment, and so we'll be reporting the findings soon. And so we're looking at how the output of that. And then the other thing we're doing is we're actually talking to people with the condition to find out what they want, rather than just us deciding what we think is best. And so we're using what we call co-creation. So we get a workshop together with people with PAD, healthcare professionals, researchers, all together in a room deciding, okay, well, if we want to improve physical activity, how do we do that? What kind of thing would work? So this CREATE study is what we're doing. What we're doing with that.
I love that, because I mean, yes, you want to think that the patients are going to do what you tell them to do, but if they don't want to do it, even if it's good for them, they're just not going to do it.
Yeah,
and it's surprising. You would think that everyone would want to do something that their doctor says is good for them, but that's not always going to happen.
No, and that's it. And you got the important thing is to speak to the experts, and the experts are those living with this condition.
Yeah.
The experts aren't the healthcare professionals, they aren't the researchers. It's the people that are experiencing it day in, day out, and it's the important people to work with.
Is there anything that our network can continue to help your team with to continue to move this research forward?
Oh yeah, I mean, it's everything you've been doing, which is fantastic. So kind of the responses to the survey that we did recently, that was really useful, and kind of learning a bit more about kind of what it's like living with PAD, and what the kind of the scores in terms of understanding about health. We talk about health literacy and quality of life. And my other student, Catherine, who was on last week, we've eventually got approval for that study, so she's launching that today in the UK group. So we're looking for people to interview, to kind of willing to share their experience, and what Catherine's interested in is just trying to understand this experience of seeking care, and what we should change about how we deliver care for people with PAD. So yeah, please, just if you're able and willing and keen to kind of help with these things, then any input is
and that one is for the UK, and we already had, I think, more than a dozen people who said, hey, I'm interested. So we'll have to send emails your way or her way, and get that moving forward, because that's really exciting. What I love, and I think gives so many people so much hope, is the fact that there are researchers that care. You don't see anything about PAD truly in the mainstream as you do with cancer. And so it makes people wonder, well, is anything being done to help me? I'm sitting here, I'm suffering, and no one knows about this. I can't even talk to my family or friends about it because they just don't get it. But it's likely they probably have it too, and don't realize that their aches and pains are exactly what you or these patients are suffering from. And they just don't know it, if at all, until a heart attack, stroke, and or amputation are imminent. And that's really sad. So seeing researchers like your team out there and trying to, not necessarily, well, we hope we find a cure, but at least find ways in which we can live with it and still actually thrive with it, and delay any sort of procedures, prevent procedures, stall progression, I think is absolutely incredible. And we're 100% in to support them.
Thank you. I really appreciate the support from the group, and the willingness to participate. It makes all the difference for us.